Good afternoon, class. Today we'll be going over Phalen's test. Just a brief summary here. We'll be going over Phalen's test, who he was, carpal tunnel syndrome, a little bit of the anatomy and involved pathology, Phalen's test itself, what it actually is. We have a little demo video to show you how to do the test. We will be going over some supporting evidence, and then we'll have a class activity. Firstly, George S. Phalen was a notable hand surgeon who was involved in a great amount of research, actually, and contributing to the body of science regarding carpal tunnel syndrome and pathologies of the hand. Now, his test that he developed is an orthopedic special test useful in diagnosing carpal tunnel syndrome by means of his own clinical experience. Just a brief review on what carpal tunnel syndrome is. It is inflammation from compression of the median nerve through the carpal tunnel. Common signs and symptoms are often radiating pain up the arm or to the first 3 digits. It's more common in middle-aged women, prevalence of 2.7% in the United States overall. Common pain, weakness of grip, atrophy of the thenar muscles if it is chronic. And currently there's no gold standard for this test upon orthopedic evaluation. In case you forgot the involved anatomical structures that go through the carpal tunnel, I have a friendly reminder right here. We have 9 tendons total going through the carpal tunnel, 4 of which are from flexor digitorum profundus, another 4 from flexor digitorum superficialis, and lastly we have flexor pollicis longus, all going through the carpal tunnel. We have the median nerve, which innervates the first and second lumbricals, abonans pollicis, abductor pollicis brevis, and flexor pollicis brevis, most of which make up the thenar eminence, and thus when it is chronic, we may see atrophy in that area. Also, we have the transverse carpal ligament spanning the transverse plane over the median nerve, and that is where a lot of entrapment happens. This is where our fascial releases come through for surgery to fix this problem. According to McGee, in order to perform this test accurately, the examiner flexes the patient's wrist maximally for 60 seconds by pushing the dorsal aspect of the hands together. It's important that no overpressure is exerted and just enough to maintain full flexion of the wrists. A positive test is indicated by tingling in the thumb, index finger, middle, and lateral half of the ring fingers. And this is indicative of compression of the median nerve and or carpal tunnel syndrome. Alright, so my patients come in with a little bit of wrist pain bilaterally, complaining of numbness and paresthesia in the fingers. I'm curious that it's carpal tunnel syndrome, given his line of work as an accountant. So what we're going to do is we're going to use Phalen's test and see whether or not it is positive. Alright, so lingus. The way this works, we're going to take both of our hands, bend our wrists like so, make sure our forearms are both level, and we're going to push the backs of our hands so our wrists bend as far as they can go. We don't want to be too firm with overpressure here, but just enough to keep it so that they're at their end range. Alright, we're going to hold it for 60 seconds. Okay. Alright, very good, Kevin. Just hold in this position. Keeping the arms level, very good. We're going to wait 60 seconds.
A few moments later.
Just let me know if you feel any numbness, tingling, those symptoms you were describing to me.
It's a little painful, starting to tingle in the middle finger.
Are you? Is it a positive result? Older research tends to show a lot of variability with the sensitivity and specificity regarding Phalen's test. More recent research that I've discovered shows quite favorable standings regarding how well this test can produce a positive result when there is indeed pathology and the negative result when there isn't pathology. Based on the current research I have analyzed, I do feel this test has strong validity. Cleland might disagree. Presenting on the top 3 cited studies that he presented in his book, the results proved quite variable. 34% to 77% sensitivity is quite a large range, as well as a 40% to 76% specificity. Overall, you could say this would be an average validity reading. Furthermore, when analyzing the Wiseman study I found from 2003, it was a study that tested the sensitivity and specificity of 6 clinical tests overall, one of which being Phalen's tests, on 30 carpal tunnel syndrome patients and 30 controls. Their highest scoring test was maintained wrist flexion with pressure for 60 seconds, which ironically not being named Phalen's test is quite a component of the test bilaterally. However, Phalen's test alone still scored a high 85% and 90% sensitivity and specificity. They also showed positive p-values of 87%, indicating the ratio of true positives to total positives. So that means they had a very good turnout with this. And the negative p-value of 89% shows the ratio of true negatives to total negatives, which is a great result. It shows that Phalen's test is useful in identifying the pathology it's intended to, and as well as ruling out the pathology if it isn't present. The Brusk study I found from 2002 also helped prove this, with a study using 112 individuals with carpal tunnel syndrome and 50 controls. This study was really more interested in the usefulness of these special tests and their validity in chronic stages of the disease. However, one reason this study is great is because subjects had symptoms ranging from 2 months to 13 years. And as you can see, that's a quite large area to cover, which kind of acts as a double-edged sword. It's good because it demonstrates the usefulness of this test across varying levels of inflammation and varying symptoms, being that it could still identify it if it's there. But for future research considerations, it could be helpful to use subjects who have had a narrower margin of symptom duration. This could potentially prove more accurate sensitivity and specificity information if the subjects are nearer to the same stage of inflammation. So the Phalen's test seems to be quite valid, but the question is it reliable? And ironically, there isn't really that much research on the reliability alone. Cleland did cite some information as well as a study I found by Marks, but I feel that most clinicians see this special test as super simple and easy to do, and therefore think it translates well across raters and is easily determinable. Citing Cleland's top interclass coefficients of 0.79 to 0.88, which is the range he provided us with, represents substantial and moderate agreement across raters. Generally, anything above a 0.65 is considered good, so we can understand that clinicians using this test agree on its usefulness of this technique and its qualitative accuracy. The Marks study below examined inter- and intra-related reliability of 7 carpal tunnel examination techniques on 12 patients with suspected carpal tunnel syndrome. The tests were administered by health professionals of varying degrees, those being hand therapists, hand surgeons, and occupational health workers. Firstly, the Cohen's kappa represents how much agreement there is across those performing Phalen tests, all while exceeding the levels of chance creating that agreement. So, most raters had moderate agreement among qualitative results, given that they had a 0.526 score. The reliability coefficient of 0.83 shows substantial reliability across raters. This number was found when Phalen's test was administered by surgeons and therapists only, and is thus more reliable when performed by these educated individuals. Lastly, our intra-rater kappa of 1.0 for therapists is literally a perfect score, while surgeons got a 0.5. This can be interpreted such that the therapists in this study have a greater ability to obtain accurate results with Phalen's test, and thus we rock. In conclusion, you should now know who George S. Phalen is and what he contributed to the body of orthopedic science in diagnosing carpal tunnel syndrome. You should also be aware of orthopedic examination techniques, being able to recognize carpal tunnel syndrome, recognizing related anatomy, and how a patient might present. When it comes to the validity of this test, although a lot of research varies, and based on the recent evidence I have analyzed, I would deem this special test valid and quite useful in the clinical examination and diagnosis of carpal tunnel syndrome. However, because this test has such an extensive amount of research showing a widespread range of validity, I would not recommend using Phalen's test as an only means of diagnosis. All of the studies I reviewed always tested other types of special tests as well, for example, Tinel sign. Since there's no gold standard test for identifying carpal tunnel syndrome, I personally feel Phalen's test should be used in conjunction with other special tests, those like Tinel sign or any upper limb tension test that can help you confirm such. In terms of reliability, for what little research I found on this test, it does seem to be reliable and favorable by clinicians. I think because the test is so simple and performed rather quickly, it's easily overlooked, and research is therefore surpassed and thought not necessary. Thank you for your cooperation and attention, and let's now give this a try. Everybody grab a partner.